guess this thing's not working. Okay, so there's obviously a lot of things for an ideal aortic valve. We all want optimal valve performance, good hemodynamics, minimal interference, very predictable deployment, low complication rates, low profile because transfemoral is clearly the most advantageous for patients, and also durable. And no one valve is going to account for that. And no one transcatheter valve is ideal for every patient anatomy. It's very different than the surgical valve where you can adjust the anatomy to fit the surgical valve. In a transcatheter valve, the anatomy is going to stay constant, so your valve has to accommodate for it, and deciding which valve is best for each patient is the challenge. And each prosthesis interacts with the annulus differently. A surgical valve, obviously you remove the leaflets, very circular. A Sapien valve closely mimics that surgical valve, but it's not always perfectly circular, and there is some asymmetry. And a core valve concept is different, where the valve is supraannular, and it tends to be more circular or supraannular, and at the annulus it sort of more accommodates the shape. And when you talk about balloon expandable, one of the advantages is, maximal area is best for optimal hemodynamics. And a circle provides the maximum area for any given parameter. So ideally, that's why I think the surgical valves are going to have, if you can get the same size valve, the best hemodynamics. And laminar flow is also important for hemodynamics. You want less turbulence. The more circularity, larger area, and less turbulence. As you get more elliptical, you get more turbulence and a smaller area. And so circularity at the annulus maximizes the area and minimizes the load on the left ventricle because you get less turbulence. And I think a balloon expandable valve is best at circularizing that annulus and providing these optimal hemodynamics. And also there's a lot of stuff about durability, and we're at the early stage. We don't really understand it. But we know just from modeling, when you have a circular valve, circular leaflets, optimal coaptation, you're going to have the lowest leaflet stress and probably the longest durability. As you get more elliptical, the stress patterns on the leaflets change, and it's going to lead to decreased durability. And I think this point is valid, especially when it comes to like asymmetric valves and bicuspids, whether it's balloon expandable or self-expanding. It's going to be different forces. And I know the core valve frames are designed to try and account for some of this, but we need longer-term data to show that. And then obviously one of the advantages is a superlinear design with core valve, which tries to overcome some of these things. But the reality is all of these things are theoretical benefits, and they're intriguing, but in the end, the most important consideration is to get the best clinical result for our patients with the lowest rate of complications. And when we're choosing, we're trying to see which valve is going to minimize these complications for any given patient and any given patient anatomy. So, and they're going to vary across different devices in an individual patient. You're trying to optimize that. We know from vascular complications that the sheath to femoral ratio predicts it, and so one of the reasons we've gotten all these alternative access, we've learned not to push the limits because the outcomes are worse, and the devices have gotten smaller, and getting to 14 French has led to lower rates of vascular complications. This is just from the partner trial. You see that the complication rates have gotten less over time as the devices have gotten smaller, but also operator experience has gotten better as well. But more and more patients are being treated transfemorally as we've gone to smaller devices with almost 90%. AR, I think we're a lot better in terms of procedural technique and sizing the valve. So really a lot of the AR is related to the last now. Early on, a lot of it was experience, sizing, implantation techniques. But now it's really just the limitations of the anatomy and the annulus. There was only been one randomized trial with balloon expandable and self-expanding. And that's shown the AR was higher with self-expanding, but there are a lot of limitations with this trial, obviously. And the Sapien 3 valve, the latest generation, it tries to address the AR issue with an external skirt. The idea is that it accommodates some of these gaps and helps fill in those gaps so you don't get leak. And in a core lab analysis, the PVL rates of moderate and severe was less than 4%. And even that mild of 40%, the vast majority, 80% is, they did a 5-point scale, and 80% of that mild is really on the mild side, and the rest of the 20 is really on the mild to moderate. This was a very aggressive grading paradigm in this core lab. And what we saw is in terms of outcomes, the none and mild had no impact on outcomes at short term, 1 year, whereas moderate had worse outcomes. Stroke is the other complication. Early on, that was the real limitation, especially with balloon expandable valves. Stroke rates were higher with TAVR than surgery, and this was in the partner 1 and raised a lot of concerns. But as we look at both devices, stroke rates numerically have been lower and bordering on significance with both Sapien XT and core valve in their randomized trials against surgery. But really with Sapien 3, the stroke rates have been even lower. Major stroke of less than 1%, in disabling stroke of less than 1%. And when compared to the surgical cohort, stroke was numerically less in a propensity-matched analysis with TAVR than surgery. And this is a big change from just a few years ago. And the stroke rates are lower because the devices have gotten better and technique has gotten better. Then obviously conduction system issues with balloon expandable valves across the different studies in general have shown the lowest pacemaker rates. I think that's been clear. What the impact of this pacemaker has been controversial. There have been differences across different studies. Some studies have suggested that the new pacemaker leads to worse outcomes. Others have not. I think there's just a lot of confounding variables, and it's hard to sort of look at that in that way. But there are other costs to a pacemaker. Especially with someone with depressed LV function, there may be less LV recovery if you have a paced rhythm, and there's more dysynchrony, increased length of stay, increased cost, and the complications related to the pacemaker itself. So, obviously, balloon expandable valves facilitate minimalist approach and help reduce costs because of this thing. And then one of the limitations of balloon expandable valves have been LVOT calcium. And we've seen several studies that have shown the risk of annular rupture is higher when you have a severe calcium below the annulus. This was the first study published showing LVOT calcium and annular oversizing the biggest predictors. But one of the advantages of the Sapien 3 is much more forgiving in terms of sizing. And therefore, the risk of annular rupture is less now with Sapien 3 than with other valves as well. So, all right, I'm going to wrap up here. It's a very stable and predictable deployment, and I think the ease of use has gotten much better because of that as well. I think that's one of the real advantages with balloon expandable valves now compared to the earlier generation systems. So I'll stop there. Thank you very much.